So thank you all for joining us today. With this panel, we're now going to turn our attention to a cancer that has profound implications for men's health across Europe, prostate cancer. It's the most commonly diagnosed cancer in men and one of the leading causes of male cancer-related deaths, responsible for around 10% of all male cancer fatalities. In this panel, we're going to explore pragmatic, forward-looking strategies to prevent, detect, and treat this disease more effectively. Central to this conversation is the role of digital innovation, how tools like MRI, artificial intelligence, and big data are reshaping screening, diagnosis, and care. Just as crucial is the need for interdisciplinary collaboration, bringing together radiologists, urologists, policymakers, industry, and patients to ensure that smarter solutions are also more accessible and equitable. So let's dive in. We're going to meander our way across the care pathway a bit, but I'd really like to start with screening, as I know that's top of mind for many in this space. There was actually just an article in The Economist this week about screening for prostate cancer. And Hendrik, I'd like to start with you. With the Praise You project, which if you can introduce what that is and talk a little bit about that, now funding pilot programs across Europe, what early lessons are emerging and what do we need to get right to scale these efforts nationally?
Thank you, Amanda. It's a wonderful question. I'm going to try to answer that within 1 hour, if I can. Men are different from women. That's very important. You see our small panel we have on prostate cancer as compared to the 7 female members that we had in the previous panel. This has a lot to do with the fact that screening and early detection of prostate cancer has been extremely unpopular a while ago. And for healthcare professionals today, they do not know too well what they have to do these days. The Praise You, I will come back to that later. But when I stopped my clinical practice, I entered the policy arena, and I have been working on prostate cancer screening. And when Ursula von der Leyen came up with the Beat Cancer Plan, we argued you cannot be serious if you do not do something about the most common and often the second male killing cancer, which is prostate cancer. And then they said, yes, we agree, but then you need to do something that takes away what we have done in the past, which was poor screening, with an enormous amount of overdiagnosis. We know in the European randomized study, 50% of men diagnosed with cancer were overdiagnosed. This means we should not have known that they had cancer and certainly not have treated them. That has been, as a consequence from that, from the United States, the Preventive Services Task Force has recommended not to do PSA testing any longer to detect cancer. And the consequence has been that the mortality has risen. I can tell you that in Belgium, we had 4 deaths a day. We now have 5 deaths a day. In the UK, you have more men dying from prostate cancer than women from breast cancer. In Sweden, it's the number 1 male-killing cancer because they smoke less. So we have had an enormous gap to fill there. And this is what we have been doing and working with Erasmus MC, with the radiologists, to really propose to the European Commission. And this has been investigated and accepted by SAPIA, by the Scientific Advice Mechanism, that if we do screening in another way, with a PSA sample, with risk stratification before any other thing, and if you are risk stratified to have a significant cancer, still no biopsy yet, before every man with a PSA above 3 had a biopsy. This resulted in overdiagnosis and overtreatment. Now we risk stratify. Then we do an MRI, and we can discuss with Jelle later which MRI you do, the capacity and so on. After the MRI, you do a new risk stratification. You biopsy pirates 4 and 5. You risk stratify pirates 3. So the number of MRIs is reduced, the number of biopsies is reduced, and the number of insignificant cancers will be reduced. And this has been accepted by the scientific advisory mechanism of the Commission, and they have then advised the Council to change the recommendations of cancer screening, not limiting it to cervix and breast and colorectal, but to add lung, gastric, and prostate cancer. The Council has got this advice, but the member states were not all very happy. And I can tell you that my own country, Belgium, and France were very much opposed to it. And there had been a compromise then by the Council that we need to do a stepwise approach, that we need to make the state of play, that we need to do the needs assessment, and then do piloting. And the EU for Health has placed a call, and the EAU, European Association of Urology, I'm coordinating the PRAISE-U, in which we do 5 pilots in the European Union. This is in Lithuania, in Poland, 2 in Spain, and 1 in Ireland. But next to that, the Council has said that all the other member states should do the same, but pay from their own pocket. And this is where we are today. We need to report back to the Commission in 2026. Is it feasible? Is it cost effective? Do men come and have their PSA? Do they follow the algorithm? This is what we need to show. We do not need to show that it decreases mortality, because that's for sure. That has been shown. And so we hope that in 2027, we will have the recommendation to start organized population-based screening. That must stop. What is ongoing today is opportunistic screening. And opportunistic screening is done in time categories, age categories, which is not correct, in too young men, in too old men. Too frequently, with the algorithm, we will reduce the cost. We will reduce overdiagnosis and overtreatment. I'm going to stop it there.
Much more to come.
This is where we want to be in 2026.
Really interesting. That's a great overview. And I think a natural segue to Jelle. I would love to get your perspective on what Hendrik shared, but also you've been quite focused on this risk-adapted screening to reduce overdiagnosis. So can you just tell us a little bit more about that and what you're working on, and sort of building on what Hendrik said, what are sort of the steps that are needed to roll this out across Europe?
Yes, I have been working with prostate cancer since, I think, 2000. In 2010, I more or less introduced a standard so that every radiologist was looking in the same way to prostate cancer. That's called PIRATS. It's internationally accepted now. So from that time on, the MRIs were standardized. And the MRIs were performed in a more in a better way than it was before. And that finally led to nice publications where it clearly showed that if you use MRI instead of the systematic biopsy, the MRI reduces the number of men that need to undergo a biopsy by at least 50%, and then screening is probably 70%. So you have an enormous amount of men that do not have a painful, risky biopsy. Furthermore, it reduces the detection of insignificant cancer. That's the cancer you do not want to detect, so that you have a reduced overdiagnosis and overtreatment. And that's also by a factor of about 50%, so half of it. And in the meantime, that is important, it does detect an equal amount of significant cancers. So MRI changed a lot of things. And we were promoting MRI not only for the clinical patient, but also for screening. But in screening, you need to be very careful that you are not using MRI too much, that you have an undercapacity, that is the reason that we introduced before MRI a risk stratification, as was said before. So you have a PSA elevation, you have a risk stratification, then you have an MRI, and if the MRI is positive, you have a biopsy, and it's an MR targeted biopsy, which is better. So in this respect, MRI appeared to be a game changer. Now the next step is to convince the local national authorities that screening in this way is the way to go for. We inherited the bad name of screening from the studies in the US and also the ERSPC without MRI, and we have to convert that in a positive way, and that is difficult. The Health Council in the Netherlands is very difficult. They have turned down a proposal for a test screening for 3 times. And now we are going to have the 4th time a proposal which includes MRI, because the previous ones did not include MRI. And we hope that that will be approved. And if approved, then we will have the results in 2 or 3 years. And in 2 or 3 years, we convince the authorities to do screening. But 3 or 4 years, that's optimistic. That's too late. The problem at this moment with the test screening is that the Health Council is only looking for the proposal of the study when the study is financed. So you have to get money first for the test screening. That's the phase that we are in now. So you go to all kind of the scientific committees and study proposals, and well, that's a hell of a job. If you then have the money, then hopefully the Health Council will say yes to the project, and then the project can start. But at this moment, the biggest problem is money. In the Netherlands, we have a multidisciplinary committee, which was started by the Patients Society, the Prostate Cancer Stichting. And that includes urologists, radiologists, epidemiologists, risk stratification. It includes pathologists, so it includes the entire team. And with this team, we are very positive. Also, the politicians in the Netherlands are positive, but the hurdle is, in this case, the Health Council. And that's a pity, because it is a game changer. It is a winner. If you look at the data of the specificity and sensitivity compared to breast cancer, the outcome of prostate cancer is a lot better. You detect more significant cancers with less, side effects or downsides for the patient.
Interesting. And I think, Richard, it would be interesting to hear your perspective on this, kind of broadening out to a pan-European policy standpoint. What do you see as sort of kind of building from what Jelle was talking about as the biggest enablers and obstacles to embedding screening in national cancer control plans, especially in light of the EU's renewed push for early detection?
Sure, it's been my great pleasure to work with Hein and many people in the EU and across other patient communities as well on this topic for a number of years, and it's been interesting to see the evolution of the issue. In terms of an enabler for overcoming challenges to screening, I suppose I would say, of course, that Europe's Speeding Cancer Plan, it has played a significant, helpful role, and I say that for a number of reasons. One is it's helped in creating new norms, if you like, in terms of a variety of different areas of cancer care. And we've talked a little bit about the, for example, EU Council recommendations on cancer screening. And Hein was relating there the thoroughness of the scientific process that guided those recommendations to be updated after nearly 20 years of being in a static position. And so that's really helped to create a little bit more energy, a little bit more accountability in countries for making progress. But also what the plan has created is communities of action, if you like, across borders. So the Praise You project, which we're pleased to be a part of as well, is bringing together 10 countries, experts from all across Europe to try and create new solutions and new guidelines to help countries move forward. So you're bringing together the best people that might not otherwise happen under an EU umbrella. And thirdly, I think what the plan has created is a much greater sense of energy and accountability at a national level. So compared to where we started from in 2019, you will see scores more countries having put in place cancer plans that either didn't have them or they'd gone rather quiet. And B, I think the stakeholders in country are able to point to things at a European level and say, why, when this is recommended at a European level, why have we not got this where we live? So the expectation it has been helpfully raised by the plan. But in terms of obstacles, I think, again, we've touched on it already a bit. In trying to make the case for prostate cancer screening to the European level, the scientists on board, the evidence behind us, but we were encountering outdated views, I think, on, it would be maybe a polite way of describing it, towards prostate cancer screening based on past approaches. And so that's all been a sort of major challenge that we've needed to work together across the cancer community to educate people about risk stratification, new techniques. And I think events like this, we need to continue to push that case beyond our normal communities. And I think we're well on track to winning over more friends and supporters.
Interesting. Interesting. That's a helpful overview at the policy level. And I'd like to pivot now a little bit toward sort of diagnosis and treatment. And Stan, I'll come to you. You've noted the really impressive survival gains specifically for metastatic prostate cancer patients in recent years. But much like we discussed with metastatic breast cancer in the last panel, access to quality diagnosis and new therapies remains uneven across Europe. What are the systemic barriers and what role can industry play in driving more equitable access?
Yeah, I think industry plays a few really important roles. I'll come back to something that Vivek said at the very start of this meeting, which is that health policy as a priority is somewhat in retreat. And I think that's really important for prostate cancer. We've talked already about some of the achievements from the EAU, from ECHO, from the clinical community to change policy and to bring new solutions, especially in screening. There are achievements, there are things to celebrate, but I think going back to your previous panel, most people in this room will be more familiar with stories of progress or stories where you are seeing data on graphs and you're seeing charts which are going in the right direction in health policy in general and in cancer and in prostate cancer outcomes. So I do think we're at a bit of an inflection point and have real challenges when it comes to making sure that progress is sustained into the future. You know, where industry can support, obviously industry has a very fundamental role of bringing new innovations, research development, clinical trials, and bringing those things to market. We don't want the current set of treatment options which are available in prostate cancer or any type of cancer to be static. It doesn't end there. It should be, you know, the treatments of today are things which started in the lab many, many years ago. And we want the treatments of tomorrow to be things which are starting in the lab now. And I think we've heard some really powerful arguments today of some of the challenges specific to Europe compared to the rest of the world, where we are declining as a clinical trial location. We have more significant access challenges, more bureaucracy, more difficulties in bringing medicines to patients. You know, one stat I find very troubling is if we look at the full availability of new innovations in 2019 and 2024, it's dropped by a quarter. And so that is essentially increasing delays of new innovations. Now, it's not all about new innovations. We've heard that very powerfully from different speakers already. But I do think that is a significant part of an aspirational future for all prostate cancer patients. You know, other areas that the industry has a strong role to play. I mean, I think, you know, supporting the clinical and patient and policy community with advocacy around things like screening, looking at what the community believes to be important and championing those causes. We've talked a little bit about survivorship already today. I think that is key, especially with people, thankfully, living longer with disease. It's ensuring that those patients and those individuals have the required support, and that there is a policy environment which supports them as well.
Definitely. I agree with a lot of the things that you've said. And I think one of the things that drives it, and you mentioned it, is data, really. So sort of transitioning to that from a policy perspective, how can we better leverage real world data and cancer registries to track outcomes, not just to inform smarter policy, but also as we think about resource allocation and addressing some of the challenges that we've talked about already? That's to the full panel, whoever would like to start.
I'm very hopeful that with the European health data space, things might improve. We have, in the EAU, we have the PRAISE-U data. Linked to the PRAISE-U data, we have now more than 10 pilots in other countries that are not funded by the EU for health. We have one in Slovenia, one in Slovakia, there's 3 or 4 in Italy, there's one in Germany. So they do exactly what we are doing in PRAISE-U, but funded from their own pocket. And we're going to gather all that in what we call the Euro Evidence Hub. Something else that is in the Euro Evidence Hub is the data from Optima. That's the big IMI project where breast and lung and prostate is looked for. Pioneer, which is just prostate cancer patients' data from all over the world. We have more than 5 million data of different patients, all in this Euro Evidence Hub. If we want to change guidelines for whatever on treatment, advanced disease, we do not need to do more and more randomized clinical trials. Go to the real data and look. You, mister, you have this problem. There we have found 120 that had exactly the same profile as you, and this is how we did when we did that sequencing of treatments. So this is really, I hope that the health data space, where our Euro Evidence Hub will be part of, will really make a big progress. One of the gaps to be filled, obviously, is awareness, and we have not spoken about it. Awareness of prostate cancer amongst the general population is simply terrible. There has been Europa WOMO, the patient coalition, have done a survey. 42% of men do not know what the prostate is, have never heard about the PSA, about prostate cancer. They do not talk about it. Men do not talk about their health, certainly not about their prostate, because there's this confusion with their sexual health and etc. So often it's ladies that bring their men to a GP to be examined when he has a prostate problem. So the awareness campaigns, how do you do that? How do we address the general population? At football stadiums, probably. In Ireland, they do it in the pub, because many men go, before going back home, they're going to have a beer. So this is where you can address the healthy population. Movember is one of these initiatives that, for instance, in Ireland, is pushing very much now in order to get a good accrual in the PRAISE-U project. So this is a big gap. And then finally, what we need is guidelines for GPs. The GPs now today, they do not know what they have to do. The guidelines, there will be a European Commission initiative, the IARC, International Agency for Research on Cancer, will lead this on. They have done breast. They're not doing colorectal, and next will be prostate, to really come with European guidelines on screening on how this is best done. And that will finally enable us and show us the way how to do in 2027.
Lots of important activity happening. I guess a follow-up question I have to that for the panel is really about, we talk about these sort of integrated data sets, but the question is partly what data we're collecting, right? And the value of that. So I'm curious about what specific metrics or patient-reported outcomes that health systems should be tracking long-term. And I think specifically, I'd love to hear your thoughts on if we're doing enough to address issues like incontinence, sexual health, mental well-being, post-treatment.
Well, I think there's obviously a lot more that can be done in that field, and I'm pleased that the European Union, through the Cancer Plan and the Cancer Mission, is supporting some initiatives in that field. So there's a project called EU On Call, for example, which is trying to help countries come together around a more standardized set of quality life metrics. And, I think the ones that are particularly important to pick up in a better way would include things like return to work, which we're not picking up that issue, which is massive for people affected, sexual health, as you mentioned, but distress monitoring as well. There's sorts of things that we can tackle much more in the Cancer Centre that are not being addressed at the moment. So I think that, again, that EU role in norm setting, this is what countries should be doing. This is well-reasoned, scientifically based recommendations. That's key, I think, to leverage some improvement.
Interesting.
Yeah, I would add to that. I think that it was mentioned in one of the sessions earlier, in future, care and what people want from treatment should be based around patient experience and what matters most to individuals. And I think there can sometimes be a somewhat of a challenge and a disconnect between what some of the regulatory authorities and what some of the payers, which is a member state competency in the EU, seek from drug developers to enable access to their medicines is often framed more around things like overall survival, things like progression-free survival, whereas things which maybe matter more to patients, like we've just been discussing, are not often necessarily seen in the same level of importance by those regulators. So I think there is definitely some education to do, and also to ensure, I think one of the panelists on the previous panel talked about patients being in the room in some of the payer and HTA discussions, but not necessarily given a voting role, not necessarily having their perspectives enshrined or taken into account in the same way as the clinical or developer perspectives. And I think that's a big concern with the EU HTA as well, and continues to be a major concern with national level HTA. And it's another thing where we actually see in many cases, particularly in big markets like Germany, actually going backwards slightly on that in terms of the role that the patient viewpoint is given within those payer and HTA committees.
Interesting.
If I may,
Please.
Stan alluded already, we're always talking about survival and survivorship and mortality. When it comes to early detection, a very important thing, and for all of them, all prostate cancer patients, is quality of life. If you are detected too late, you become metastatic, you become castrate refractory. You get an extension of your life, your quantity of life, you gain today 3-4 years with drugs, with a very bad or mostly poor quality of life. Without testosterone, you are castrated. With the side effects of all the drugs that you get an extension of your life, indeed, with a poor quality of life. You're asking a question on incontinence and sexual problems after treatments for early detected disease. If you are screened and you have localized prostate cancer that is timely detected, you can have a nerve-sparing radical prostatectomy. You can get radiation treatment without adjuvant castration. You can have a sphincter sparing, a bladder neck sparing surgery. The likelihood that you have incontinence is still there, but it's very low. And if you have an incontinence problem, it can be solved. So as far as that is concerned, your quality of life will be reasonable. If you are impotent because the tumor was maybe on one side extracapsular and we had to take one neurovascular bundle away in order to take everything out, a man of 70 will not recover his potency. A man of 50, he will. After 9 months, he will recover with one nerve, will be sufficient. But if impotence, erectile dysfunction is a problem, there is solutions for it. There's intracaverous injection therapy. Everything exists. So still, if you suffer complications from an early detected, from a screen detected tumor, your quality of life will be okay. And if it's not okay, we can take care of it. But a too late detected cancer, he has a terrible, terrible end of life. And we all know how prostate cancer patients in the end die. They die because they have pain. And because the doctors taking care of them give them so much morphine that in the end they stop breathing. That's the death of a prostate cancer patient. And this can not be avoided in all, but in many, if we can have population-based screening programs.
Interesting.
Yeah. And you just, if I may add to that, you mentioned, of course, the morbidity for the patient, loss of quality of life. But don't forget that the treatments of these patients are a factor 10 or even 50 times higher as compared to the patient that has a prostatectomy and then nothing. Hormonal therapy is very expensive. It is effective, but there are costs involved. So that also is a significant problem. All the re-imaging that you need to do to see whether you're a responder or a non-responder, that also adds to the cost of healthcare. And it's better to detect prostate cancer early on. It has been shown not only to be beneficial for the patient, but also cost effective. And concerning treatment in an early phase, at this moment, it's not yet in the guidelines, but there are about to be. There are many minimal invasive image targeted therapies at this moment being performed. You talk about HIFU, focused ultrasound. You talk about ERE, electropoiesis. You talk about focal laser ablation. You talk about MRI HIFU, TULSA. Those techniques minimize the damage that needs to be done to remove the tumor. And you can imagine if you detect a tumor in an early phase, the damage is less. So this all brings a significant decrease of the burden of the patient. So we need to go for screening, but we need to do it in the right patient. The patient needs to have the right age, the right conditions. And I agree that we should have large databases with the genome and the phenotypes being described. Phenotypes is imaging, that is MRI. We have DICOM data, and at this moment we should also consider in collecting those DICOM data images, because on those images with artificial intelligence you can calculate many things, also in the future for future therapies and future diagnostics. But don't forget pathology. At this moment in the Netherlands there is the PALGA, the Dutch registry of pathology, which is also digitized. And we also need to bring that in the next level, bring that into the database of, well, the prostate cancer patients, including the genotype. And I agree with the previous speakers that based on such an enormous database, in the future we can do many research to see whether a more individual approach fits better.
Interesting. I'm glad you mentioned the future, because we've been talking about a lot of sort of promising technologies and innovations and improvements in the way that we both detect and treat prostate cancer. I'm going to take questions in just a moment, so get them ready. But I'm curious, as we think about the future, sort of what is the one change, or not just one, but a key change, whether in policy, technology, or we heard in a previous panel today about mindset of policymakers and the public, that you think would most transform prostate cancer outcomes in Europe?
I have a very clear answer. There is one thing that we need to solve. We need to recognize on the profile of the patient, on his risk stratification, and on the biopsy, on the pathology, and with the markers that we have today, whether this cancer is going to kill that guy or not. We have the possibility today that in diagnosed prostate cancers, for 20%, we can foresee you will not die from this cancer, sir. So don't do anything about it. And this number should increase. We probably still treat actively patients that would never die from it. You know that there is a bunch, not a bunch, there is a number of patients with metastatic disease that do not die from the disease. That's important to know. And that's the research that we need to further focus on and where we should have funding to do the research. Which cancer diagnosed is mortal and which is not. And then
agreed.
the whole issue about screening or no screening is over.
I mean, I think the EU Council recommendation on screening was really powerful, and I think what's happening now with PraisU is a model. I think that what's going to be critically important moving forward is that is activated and acted upon at member state level. And I think too often there can be a somewhat of a disconnect. I think we see it in other areas of the Beating Cancer Plan. ECHO's done amazing work of trying to take those EU level priorities and take them to member states. But I think that, this is one very strong example, and I agree very much with Hein that having the implementation of that process and those recommendations will be very transformational.
Great. I'll take a question. I saw your hand first. Yeah.
Peter Kapitein from Inspire to Live, the Netherlands. Hi, Jelle. I like the background of your screen. I think next year put a patient advocate in this panel, and the reason why is not because but I hear a lot of policy, but I know Jelle for many years now, and he is doing it. Yeah. So we do not execute what we already know. And we can talk about policies, we can talk about innovation, but the moment we implement what Jelle knows, what Hein knows, we are already helping hundreds of thousands of patients in Europe with the knowledge we now have. So I plead for a stop on innovation, but for a speed up of implementation. That is necessary. Really. And I admire the work. I know Hein pretty good. I admire his work. I admire Jelle. I know him very well. They both have a passion for patients. And the cooperation between patients, researchers and physicians will be the breakthrough. Because policymakers, government personnel will not be able to stop the combination of patients, researchers and physicians. So execute what we already know.
Thank you, Peter.
Thank you. Yes. And I'll be in touch with you about next year for this panel. Thank you for your comments. Really important. Any other questions in the room or any reactions to what Peter said?
Well, maybe I just think what you're relating there as well is the great need for continuity and building on foundations. I think things like the PraisU project, the Council recommendations, those are a very firm basis for future EU prostate cancer policy. But there is sometimes a bit of a habit, occasionally with European Union policy, that you start something and then move on to the next thing. So I think it's a message maybe to our MEPs or Commission colleagues that are here that let's build on what we've created, because the potential is massive.
Definitely. Any other questions? No.
We must have been very
In the back of the room here. Someone must have a question.
I'm Walter from Cambridge. I just want to know if there is like a late effect team for like prostate cancer. Basically like a team that deals with maybe people who suffering from late effect from cancer, from prostate cancer.
Does anyone want to come in?
I did not.
Late effects.
I did not understand the question.
Are there any initiatives for late effects of prostate cancer?
For side effects?
Late effects.
Late.
Late.
I do not know what you mean.
Like after treatment, that you may experience.
What we can do for late side effects of treatments? As I said, for localized prostate cancer that has been treated actively, we can cope with the complications. The complications of castration obviously are heavy. It induces osteoporosis, fatigue, depression, suicide. The late side effects of chemotherapy are well known. The side effects of the new upcoming treatments are not well documented yet, but we're working obviously with the companies in order to reduce them as much as possible. I think that's about all I can answer to this question. That was maybe not very clear to me. There's another question over there.
Sure.
I can cast my voice if you can hear.
If you don't mind, yes, please.
I mean, I don't know what to comment on this, but I really think that more should be done in regards to public health for men, especially, as we know, in regards to sexuality and having to be examined. Coming from very much a Black community, and I'm involved in so many different organizations, being the founder of BAME Health and looking at all of that. One of the issues that we have with our men is that you were saying rightly in all communities that the women actually encourage the men to go and get tested. But, you know, we see so much in the media about breast cancer. They have the really pretty pink ribbon and everything. And I think the whole agenda should be actually changing how we view prostate cancer. And I just think how we can tap into other communities in order to do so, because by the time it's diagnosed, it's ever so late. And I just think that men's health on the whole, not only prostate cancer, has really taken a backseat since COVID. It's really taken a backseat, including with mental health and all of that. But we're here for prostate cancer. And I'm a little bit concerned as a healthcare practitioner myself that we have clinics, we have breast clinics, men get breast cancers, we have clinics, but we want men to come in the same clinic with a woman, and how do they feel? We don't have specialized clinics that run after hours, that they can actually have that kind of care that they need and support. If you do a search right now on Google and look for prostate cancer support for men on a one-to-one or whatever, I think we're falling behind here, but mortality is real. Thank you.
Thank you.
I think
I think indeed, if I may, I think indeed we need to set up specialized centers, just like the breast centers, for diagnosis and treatment advice. That means that if you have a problem with prostate or prostate cancer, a question, you will go to a specialized team where your PSA is tested, your PSA density, you have a risk calculator. If necessary, you have all kinds of genomic tests. You have a specialized MRI done by an expert team. Then you have, if needed, a biopsy which is targeted towards the lesion. And then all the information is collected, is being discussed in an MDT, and then the patient gets, well, what is wrong with his prostate and the treatment advice. And then he can go to his own place or wherever to get the right treatment. That's also being given an advice. So I strongly think that we need to think about setting up specialized prostate diagnostic and treatment advice centers. And you can combine that with breast centers. You have the pink and the blue ribbon. They can go together if you want.
Exactly.
I like that.
It is easy. It can be done. A diagnostic center, if you have all the equipment, ultrasound, an MRI, a staff, a team, urologist, I think with the beginning cost of 5 million, you have such a center. And there are more and more ideas to set up such centers, to get them out of the hospital and put them in between the GP and the hospital. We call it 1.5 care, not in the first line, but not in the second line, but in the 1.5 line. And such centers, I think, will be enormously beneficial for men and for GPs, because the GPs know where he should send the patient to. Now he doesn't know. I go to Hospital X, and Hospital X has a good radiologist? I do not know. A good pathologist? A good urologist? Well, perhaps. So this is my plea.
Thank you. Thank you. And unfortunately, we're out of time. I would love to continue this discussion because all these points are really important and interesting. But I'd like to share a warm thank you not only to our panelists, but to all speakers, sponsors, and delegates for being part of this track and day one of the 10th Annual World Cancer Series. So thank you to the panel, first of all.
Thank you, Amanda.